And history of no history of noticing any abdominal distension, mass, no history of jaundice, pain, chest pain, and night sweats and prodromal symptoms prior to the onset of this problem, no history of loss of appetite since the onset of present problem, history of aversion to increase pain with the intake of food. No history is suggestive of early satiety. Patient lost weight 5 to 6 kgs in a month, and he was previously 58 kg. Now his weight is 52 kg. No history suggestive of bowel disturbances. No history suggestive of constipation. He was history of constipation for first 15 days, which was relieved by the laxatives. No obstipation. No history of passing black and tarry stool. No history of any other altered bowel habit. No history of abdominal distension and jaundice, easy fatigability, breathlessness, cough, hemoptysis, headache, seizures, or dizziness. So past history of retro positive pain since he was retro positive, matlab HIV positive since 10 years on ART. No other comorbid illness, diabetic hypertension, no history of any recurrent episode of pain, jaundice, and fever, no history of typhoid, no history of any drug intake and blood transfusion and tattooing. He was married with two children, smoker since 30 years, smokes one pack BDs, quit a month back. History of alcohol consumption 20 ml per day for the past 30 years, quit a 1 month back. Took a mixed diet, sleep was normal, no bladder bowel, no history of loss of appetite. History of loss of weight was present, ma'am. Loss of weight and appetite was present. Bladder habit was normal. History of constipation and no known allergies. No significant family history. So, to summarize, 63-year-old gentleman, progressive, non radiating pain, moderate intensity in the right upper quadrant, dull, aching, persistent, pain aggravated on the food, fatty intake, relieved partly by analgesic, with no postural and nocturnal variations. Fever, any prodromal symptoms or jaundice, similar episodes in the past with a history of notice, significant loss of appetite and weight with no symptoms of suggesting of distant meds.
Okay, so we'll start discussing uh, from first. Like, what is the main thing here? He is having
Weight
pain abdomen.
loss with pain in
Pain
abdomen.
abdomen with significant loss of weight. Okay, and other than that, there is no history of any prodromal symptoms. So first, go to the first page. Yeah. So this demographic data, does it have importance in CA gallbladder?
Yes, ma'am. It is a known risk factor if the patient belongs to gangetic belt. There is high risk of gallbladder cancer in that area due to
Okay.
in Ganga water, high amount of heavy metals are found. Is recently proven in last 5 years that arsenic is the one of the risk factor which frequently found in Ganga water. So it's one of the high risk for the gallbladder cancer.
Okay. So what is the age of in this? This is the age of patient is 63-year old. Okay.
Yes.
What is the age of presentation for CA gallbladder?
CA gallbladder patient in India per se is like 50 to 60 years.
Okay.
Younger as
So
compared to other countries of the world.
okay. So other than that, so what are the presentations of malignancy of a gallbladder? How do they? How? What are all the symptoms that they can present with?
Jaundice, painless jaundice is the most common features, or pain in the gallbladder, and
Can they present with jaundice?
yes, ma'am.
They can present with jaundice. Okay. Yeah, but painless jaundice is one of the symptoms. Most commonly is the pain abdomen, right upper abdomen. Okay.
Hmm.
Then what else?
Mm. Palpable mass, painless lump.
Uh, Patient telling about the mass is little rare because we feel it on palpation. That too on deep inspiration. That is the most common presenting. I mean the sign, not symptom. Okay. So other than that, they can present with dyspeptic symptoms. Okay.
Dyspepsia. Yes, ma'am.
Yeah.
Dyspepsia
And
not relieved by any antacids.
mm. And what else? Your patient also has that history. What is that?
Mm.
Weight loss?
Weight loss and loss of appetite.
Yeah. So you can divide your presentations into early presentations or advanced presentations. Okay. So early, most commonly, gallbladder presentation is asymptomatic. They come with some vague complaints like on and off pain, right upper abdomen, or some dyspeptic symptoms. Okay. Not pointing specifically towards any malignancy. Okay. Then comes abdominal pain. Okay. This is seen in around 60 to 90% people. Okay.
Yes.
And weight loss, around 70% people they present. Okay. In jaundice, they present in
30%.
around 13 to 50%. Okay. So in metastatic case, they may present with
Hepatomegaly or jaundice.
yeah. So jaundice. So once upon a time, patient whoever had gallbladder CA, if they presented with jaundice, it was considered sign of inoperability. Okay, but further studies have told it's not inoperable. You can always give NACT and then take up for surgery. Okay, if it's not metastatic.
And sometimes it's due to obstructive, due to jaundice.
Yeah, it
due
is
to
not
the stone. Polylithiasis also.
Yeah. So yeah. So whenever you describe about pain, you describe everything like this. Okay, relation to posture, relation to food. Okay, so gallbladder cancer, can it present with any referred pain or radiating pain?
Usually,
If so, it is
non-radiating. Matlab, if it is radiating, it means it's advanced.
right shoulder pain.
Right shoulder pain when it is perforation or ascites or
No.
something like that.
So basically, any irritation of diaphragm, okay, will cause that referred pain. Okay, can it present with back pain?
Back pain usually pancreas, ma'am.
Yeah. So usually it is pancreas, but in advanced cases, if there is metastasis or anything, they can still present. Okay.
If enlarged level 13 lymph node, it can be present with the back pain, radiating back pain.
If can there be possibility of gastric outlet obstruction?
Yes, ma'am. It advances stage, it's the loss of planes with the duodenum, which can be one of the cause of gastric outlet obstruction.
Can it present with the abdominal distension?
Ascites, yes, ma'am. Ascites.
It can present, okay. It can present with any swellings anywhere else in the body. Means lymphadenopathy, okay.
Supraclavicular lymph node palpable.
Yeah, all this not only supraclavicular, it might be umbilical nodule. Okay, past history of any cholecystectomy is also important. Okay, any site or swelling or hardness at the site of both sides, all this are important if there is a past history of any surgery done. Okay. So next. Sorry.
Past of gallstones more than 3 centimeters.
Yeah, treatment for gallstones is very important. Okay, so past history for any acute episode, or any history of any surgery in the past. And see, in first instance, when he presented with right upper abdomen, what all the differential diagnosis comes to your mind?
In right upper quadrant, pain if patient presenting, most common is gallbladder cholelithiasis, most probably is most common. Otherwise, it can arise from any colon disease or any liver abscess or benign disease or liver malignancy in advanced cases. So mainly, and sometimes if kidney upper lesion or pyelonephritis can also be present in the right upper quadrant.
Can it be any chest pathology?
Pleural effusion can also be pleuritis.
Pleuritis can present. And so it can be chest pathology. Okay, it can be any liver issues, be it any abscess or any mass, okay, in the liver. Sorry?
Hydrated?
Yeah, it can be hydrated. Means one of the differential diagnosis, if it is like some vague symptoms, to rule out any inflammatory causes, okay. And anything else, anything other differential diagnosis? You told me about liver, you told me about the chest pathology
and colon.
okay.
Right colon.
Colon.
Hepatic flex.
Yeah, colon. Yeah, hepatic flexure of colon. Anything else?
Can we say pancreatitis, acute pancreatitis?
Mainly it's in
location is
epigastric region and radiating to
Yeah,
back.
right hypochondrium, little it is not very common in right hypochondrium.
But
per se, but it
CVD
is an
obstruction
epigastric.
or choledochal cyst can also present like this. Choledochal.
Cholecystitis? Simple cholecystitis?
Simple cholecystitis or chronic cholecystitis or that CBD stone, choledocholithiasis,
viral hepatitis. Viral
hepatitis.
hepatitis. Viral hepatitis.
Any obstruction to the duct by parasites?
This ascariasis, filariasis, क्या था? Florensis sinensis.
Yeah, liver flux. Okay. Then, okay, colon over, kidney rare, but okay. Colon, liver, chest, anything else?
Duodenum.
Yeah. Peptic ulcer?
Peptic ulcer can
Distal
mimic,
gastric.
but it usually epigastric.
Duodenitis.
Yeah, it can present pain in the right upper abdomen. Okay. Yeah. Then duodenitis. Okay. Anything else? Can it be a lymph nodal mass?
Yes.
Causing this symptom? Lymphomas. Okay. So all these are
mass can cause OJ also, no?
Yeah, it can cause OJ also. So main thing at this with the pain, you have all this differential diagnosis. Then you will ask for history of fever with chills and rigors. Okay.
Yes.
So this whatever we discussed in pain, all the inflammatory causes might be associated with fever with chills and rigors. Okay. What is the triad for? What is that name of the drug? No, Reynolds and Charcot triad. Yeah. What are the Charcot triad components?
Intermittent pain, jaundice, and fever. Mental septic shock and mental disorientation in Reynolds pentad.
Mental obtundation, okay, and shock. Reynolds pentad, okay. So, suppose you go to the next page. We'll discuss. So, dyspeptic symptoms to rule out any peptic ulcers. Okay, as such, the gallbladder symptoms also. Okay, cholecystitis might be associated with this. So something tells you that it is not relieved with antacids. Okay, so it's not gastritis. Okay, so when gastritis still can be one of the differential diagnoses. Okay, till this part of your history. Okay, so then Why I asked about abdominal distension?
Ascites
Okay.
or
Yeah, ascites. Okay. These are all, next to all whatever symptoms I have mentioned, they are metastatic symptoms. Okay. What is significant loss of weight?
more than 10% of body weight in 3 months.
6 months.
6 months.
6 months.
6 months. Okay. 10% in 6 months.
Or 5% in 1 month.
7.5 3 months, 5.5% 1 month.
Yes. So,
5%.
what is difference between anorexia and cachexia?
Cachexia will be associated with loss of weight and nutritional deficiency, while anorexia is simply loss of appetite. Severe malnutrition or musculoskeletal.
You are
Cachexia is
correct.
a constellation of symptoms.
What is sarcopenia?
Sarcopenia. Sarcopenia.
Loss of muscle.
Skeletal muscle bulk.
Okay.
Yes. So only loss of appetite with aversion to food intake will be anorexia. Okay. But when it is associated with the generalized symptoms associated with muscle loss, all this will be constellation of symptoms with cachexia. Okay. So, okay. Why I asked about black colored stool?
Typhoid.
No, think simple, no? Okay, till now you have not come to your diagnosis of CA gallbladder. Okay, right? So don't tell
The
in terms of your
colon
history.
cancer, to rule out colon cancer.
Duodenal ulcer, pain, right?
Yeah, see,
Gastric
upper
outlet,
GI
belly
pathology,
bleeding.
na?
Bleeding.
Yeah, Melina is asked for. Okay, so you
But
still don't have a conclusive evidence that it is a CAGB. CAGB is not direct diagnosis. Okay, unless it's confirmed. Means at your level of history, you can't tell. It is one of the differential diagnosis. Okay, so keep all the DD we have discussed in mind till now. Okay, so to rule out each DD, we ask the symptoms. Okay, history of melena or history of altered bowel habits. Yeah. So you also told colon, right? So you told the stomach. So all this are one of their symptoms to rule out all those things. So when you complete your history, you should it should boil down to some 3 or 4 differential diagnosis. That's it. Okay. Next.
Why history of bladder disturbance?
No, that is for completion sake. Okay.
Yes.
Nothing in relation to this particular symptom. Okay.
Yes.
So why history of typhoid or tuberculosis?
Typhoid is the one of the risk factor for CAGB and cholelithiasis also. But TB, I don't know, ma'am.
Drugs can cause cholestasis. ART drugs and TB drugs cholestasis hota hai.
Yes. So here he is taking ART also. Okay. So and anything in relation to immunosuppression as such. Okay. So your other comorbid illness and all you ask in terms of treating to further manage. Okay. Why I asked history of recurrent episodes of abdominal pain, jaundice, fever?
This is can be due to cholelithiasis or any is history of chronic cholecystitis to rule out.
Okay. So you means to say the past history of chronic cholecystitis. Why abdominal surgery?
That cholecystectomy history is very important if patient is having cholelithiasis in the past. Cholelithiasis itself is a risk factor for CAGB patient to one of the CAGB cause.
Okay. And also, if there is any not in this case, but if there is any jaundice, any history of
Choledotomy.
previous abdominal surgery for any strictures. Okay,
Okay.
post surgical strictures. By drug intake, he already told. Okay,
Cholestasis.
so can you tell me some drugs which cause cholestasis?
Ceftriaxone group.
Cephalosporins
Cephalosporins.
and then
I think anabolic steroids.
anabolic steroids. Anything in antibiotics? Any antibiotic group other than cephalosporins? You told ATT, ART, so sulfonylureas. Okay, all this are
Sulfonylureas.
one of the drugs that cause cholestasis. Why blood transfusion?
Blood transfusion is a risk factor, ma'am.
No, I don't think so.
It is not a risk factor. We are ruling viral causes of hepatitis. We have
Viral
not
hepatitis.
Yeah,
Hepatitis.
viral hepatitis. That's why you'll ask. Okay. Why tattooing? Same reason.
Viral
Okay.
hepatitis.
So hepatitis causes. Next. So since that is DD. So what is important in personal history?
For CAGB.
No,
Smoking.
not CAGB. In your forget CAGB. In your history of presentation, in this case, what is important? Personal history.
Patient was a smoker and alcohol consumption.
Smoking is a risk factor. Okay. For if still you have not come to conclusion that it's a gallbladder, so it can be liver. Okay. So alcohol.
High risk behavior also.
Yeah, high risk behavior also is important. Okay. So then. So next page.
In family history, I read, ma'am, some 7q21 chromosome is responsible, have ABC, CB1 and B4 gene, which are responsible for hereditary gallbladder cancers. So family history.
In other words, what are the association syndromes which have gallbladder cancer as one of the component in them? Normal syndromes, from some syndromes we read, no?
Hinge syndrome.
BRCA2. Okay.
BRCA2. BRCA2, pancreas.
Hepatobiliary and GB.
Okay.
Next.
And MTC?
Medullary thyroid cancer.
Ma'am.
What syndrome?
What, gallbladder cancer, biliary tract कहाँ पे?
No, it is not there
उसमें
with gallbladder.
pancreas में insulinoma वगैरह रहता है उसमें.
FAP वाला, sorry, FAP वाला.
FAP, yeah. FAP is associated. Then HNPCC. Yes, HNPCC.
मैम almost all FAP and Lynch सब में बोल सकते हैं ना? पूछा तो.
You can tell, but HNPCC in specific, it is associated with GB cancers. Okay. Then, okay, fine. So, from your history, okay, after summarizing the case, what do you think? Give me 4 differential diagnoses in that order which you think it could be.
Chronic cholecystitis. Chronic
cholecystitis is your first diagnosis?
Yes, ma'am, because it's the one of the most common cause of pain in the right hypochondrium. And
there's no fever?
That's why I called chronic. If fever hota, to I would have gone for acute.
There are no recurrent episodes of right upper abdominal pain. So that's why I told in order. Go out of GB and think. Okay, not necessarily it should be GB, right?
Yes.
Ma'am, can it be a chronic? If you rule out GB mass, can it be a chronic pancreatitis also? Like food intake, fatty food intake, upper abdominal pain,
It would
Recurrent
never be
episodes of
dull aching pain
upper
for
abdominal pain
alcoholic,
is not there. Recurrent episodes are not there.
severe pain
Okay.
होता है pancreatitis में.
So this person has some pain which is progressing over period of time, but he doesn't have any similar episodes of pain in the past. Okay, so it with no history of any fever. So still, he being immunosuppressed, you can give that point. He being immunosuppressed might have not manifested fever as one of the presentation. Okay, so it can still be chronic cholecystitis. Okay, and it can be either benign or malignant. Divide your DD into benign and malignant. In benign, it can be due to cholelithiasis leading to cholecystitis. Next. He has dyspeptic symptoms.
Yes, gastric ulcer.
Yeah, it can be gastritis, gastric ulcer. Then, can it be hepatitis?
Hepatitis.
He is immunosuppressed.
no fever.
Okay. He is immunosuppressed.
Okay. But jaundice, not all patients of hepatitis present with jaundice.
The jaundice. Right. You're right. Then, can it be CBD, choledocholithiasis?
Choledocholithiasis have intermittent pain usually, and means colicky pain. That is this is dull aching and continuous pain.
Okay.
There can be
Then?
history of jaundice also.
In neoplasm, what will be the first diagnosis?
Neoplasm can be CA gallbladder, can be liver mass.
Yeah,
But
it can be
this,
still HCC.
And but this relieved by fatty diet, aggravated by fatty diet, won't be a symptom in liver mass and colon mass.
Yeah, it goes against, but it can be given as down the, as second or third malignant DD. Okay, so you still have a broad DD at the end of your history. Correct?
Yes.
So next,
Now,
on
should we
examination.
give, malignant DD first before benign, considering significant loss of weight, loss of appetite?
Yes. In this case, your first, if you are asked in order, I would like to rule out malignant etiology first.
Ma'am,
In
actually,
view of
I heard today that ISO video, the same symptom was 1.5 months back, and definition says more than 10% in the 6 months or 3 months, 6 months now. So sir told ki your history is less than 6 months, then how can you calculate more than 10% of weight loss? This he was.
You can say 5%
there's
weight
1
loss.
month also, no? There is one definition for 1 month.
Like this
5% in 1
6 months, 7.5% in
3 months and
1 month 5%.
Yeah.
1 month 5%.
Yeah.
And that also, it is unintentional weight loss.
Yeah, without any, like they doing diet or anything. Okay. So, okay.
They
So,
have scope, and he has given the first TDCAGB, and they were like
no,
banging
what
on
he
him.
presented, what they presented in ISO had different symptoms.
No, most
He did not
probably have pain and no jaundice, and with all this dyspepsia and all, and weight loss and loss of appetite. These only the two symptoms which he was also saying, which concluded that patient is going for CAGB.
Ma'am, our एक doubt थी, he is presenting for the first time, keeping apart neoplasm. If we have to talk about benign conditions, we have two options considering as a GB etiology, either acute or chronic. Since it is the first time and there are no episodes of fever and all, we cannot call it as acute like cholecystitis or chronic cholecystitis, cholelithiasis. एक ही episode तो present हो रहा है ना? How can we say benign things if you want to say? How do we support that?
you can tell that the manifestation of symptoms were not there in this case because he had immunosuppression. Okay, you can still give the chronic episodes. Okay, so
Chronic means he should have similar episodes of pain, at least pain earlier. No, this is the first time he's presenting, though he's immunosuppressed.
no, this can be if you tell it as acute, so they should have
That is
all
not the
that.
problem.
Yeah, that's why you should chronic is safe. If you want to tell benign, you should tell it's chronic only. Okay, so
Then they can ask, did he have similar episodes earlier? We are telling in the past there are no
Yep.
similar complaints in the past.
Yeah, that's what he gives. No history of similar complaints in the past, sir. But in view of his immunosuppression, I don't think he had symptoms that manifested that he actually told that there were any similar episodes. I mean, he did not.
No
I
unnoticed
mean,
symptoms.
yeah, he did not have any significant symptoms that led him to seek medical attention. So, because of his immunosuppression, I still think that there were some similar episodes which were not very significant. So, it can be still chronic cholecystitis. You can support your answer like that.
Okay.
So, examination.
I examined my patient in well-lit room with proper informed verbal consent in the presence of a male attendant. General physical examination, ECOG performance status 1. Patient is well oriented to time, place, person and moderately built, well nourished. Height 166, 56 centimeter, weight 52 kg, BMI 21.76. Vitally stable, no pallor icterus cyanosis, but grade 2 clubbing present, no generalized lymphadenopathy, no supraclavicular lymph node, no lower limb edema, gait is normal, no signs of any liver failure.
Okay. From your general examination point of view, in your case, what is important?
Most important, ma'am, eyes. Icterus.
First of all,
Signs of
build
liver failure.
nourishment is very important. Okay.
Cachexic,
ECOG
ECOG
status.
performance status is important for you to treat. Okay. Correct, no?
Yes, ma'am.
Yeah. And BMI?
Obesity is the one of the risk factor of CAGB.
Yeah.
And
So,
for operation also, obesity is a high risk for
yes.
large surgeries.
Even otherwise, if patient is malnourished, it's a problem, no? So, for you to take up for
less than
hepatobiliary
18
surgeries.
BMI is like a high risk factor.
Yes. Next. What about vitals? What is important in vitals?
Vitals, if patient just should have normal vitals, means patient is not in shock or
Temperature and pulse.
tachycardia is also a sign of inflammation.
Yes.
Since patient
So,
is
fever, tachycardia, these are the things. Then yeah, in the general examination, what is important?
icterus if OJ, and supraclavicular lymph node is the metastatic disease, lower limb edema, nutritional status. And since patient was chronic alcohol consumption, so signs of liver.
Nutritional status it could be generalized. Now, why only lower limb? It points towards something else, IVC obstruction kind of thing. If nutrition is not correct, it would be generalized.
But lower limb edema is the most common where we elicit usually patient for ascites. If patient ascites abdomen में भी होगा, local abdomen ascites we can see. But one of the common symptom we usually see in the lower limb edema patients with a nutritional status. Ma'am, what you say?
What? see, lower limb edema is something compressive symptoms. I mean, the compression causing. But generalized anasarca will tell you about the nutritional status. Even the otherwise other nutritional status is but by the skin fold thickness. Okay.
But
Midarm circumference.
nutrition, if they ask how do you assess nutrition, we start from head to toe. From head we start from hair. The hair will be brittle. Then we go to forehead. There will be temporization. Then go a bit lower. Malar prominence. Go bit little lower. There will be cheek inwards. Then go little bit lower. There will be suprascapular. The clavicular recesses will be there. There will be squaring of shoulders. Go little bit down. You will see intercostal muscles will be
drawing.
Yeah, muscle. Then go a bit lower. You will see scaphoid abdomen. Go a bit lower down. You will see prominence of bones. You will see prominence of the iliac bones.
You see muscle resting.
Yeah, go a bit lower down. You will see prominence of tibia, prominence of femur, prominence of this knee. Go a bit down. You will see pedal edema. So from top to down, if somebody asks how do you assess nutrition, then comes anthropometry. You will see skin fold thickness. You will see biometry. You will see BMI at the end.
Tell me, like in chronic, how do you assess for protein loss? Okay. Yeah, you tell me this. How do you assess for protein loss? What is the
triceps thickness?
And
actually, there's a patient subject to global assessment. If they ask, how do you properly assess?
Fat loss and protein loss. So how do you assess?
Sacral edema.
Protein loss is by muscle mass.
Yes.
Loss of buccal fat.
I don't know about this, ma'am.
So, the loss of buccal pad of fat, the malar thinning, and then the scaphoid abdomen, all these are fat loss. Whereas the triceps fold thickness and midarm circumference are for protein.
So there should be one normal limit, ना? We will decide कि इससे कम होगा, then it will be muscle loss. ऐसा कुछ होगा, I think.
Yeah, but I don't know the numerical. Okay. So
to see exact muscle loss, it is only by CT. You can see that just generalize. He looks thin, lean.
But उसका कुछ है ना, sarcopenia पहले separate रहता है.
CT sarcopenia index by source muscle, or we can see other muscles also.
What are signs of liver cell failure, Saumyta?
Liver cell failure, ascites, tremors.
Start from top. Head to toe. Yeah. Start from top. Head. Slowly you tell.
Icterus.
Alopecia. Bilateral.
बाल से शुरू कर.
Loss of hairs.
Yes. Eyebrows.
Eyebrows नहीं है पता.
Bilateral parotid swelling.
Bilateral parotid swelling.
Gynecomastia.
So there are signs of decompensation versus signs of liver cell failure. Okay.
Yes, ma'am.
So they are different.
Flapping, some tremors are the signs.
That is encephalopathy.
So there, I'll tell all combined. But this, some of them are decompensated symptoms. Some of them are signs of liver cell failure. Okay. So this first is that loss of hair, loss of lateral part of the eyebrows. Okay. Then there will be parotid swelling, fetor hepaticus. Okay. Then
foul smelling of from mouth is fetor hepaticus, no?
Yes. And then Dupuytren's contraction, palmar erythema, spider knee, the nail, leukonychia. Okay. Flat nails. And then this one, gynecomastia,
testicular atrophy.
Then there might be ascites. Okay. Testicular atrophy and
hyperestrogenism के कारण ये सब होता है. gynecomastia and
spider nevi, all these are due to that. Okay. And Yeah. So these are the measure. They are again divided into signs which are specific to liver cell failure and signs of decompensation. Okay. So yeah. Next one.
Why gate? I just want to know why gate, just completion sake or something related to any pathology?
No, it's for completion sake.
Okay.
Yeah.
On inspection, abdomen is not distended, umbilicus in the central position, uh, respective quadrants moving equally with the respiration, no scar, sinuses, dilated veins, and no visible peristalsis. Fullness in the right hypochondrium region is present, and the hernial orifice appears to be normal. On palpation, I confirm my inspectory findings and no local raise in temperature over that area. Non-tender findings: well-defined globular mass of size 5 into 4 centimeter in the right hypochondrium region, just below the right subcostal margin, and irregular surface and well-defined margin, firm in consistency, moves with respiration. Lower medial and lateral borders are palpable. Upper border is continuity with the costal margin. However, the fingers could be insinuated between the costal margin and the mass. Side to side intrinsic mobility is noted. No hepatomegaly or splenomegaly, no other palpable mass, no palpable lymphadenopathy. Hernial orifice and renal angles are normal. External gelateria is normal.
Okay. So
And
okay, you complete the percussion one, then I will ask.
uh, liver span is 12 centimeter in mid-clavicular line. Dull note over the mass present in the continuity with the liver. Dullness, no free fluid on auscultation. Normal bowel sound heard, no brood heard over the mass. PR sphincter tone is normal. Rectum is empty. No ballooning of rectum. No growth and deposits felt. No bleeding per melena or no finger staining.
The
Systemic
rest of the systems are
examination is
normal.
normal. So to
Okay.
conclude,
Now,
63-year-old.
in your examination findings, okay.
Yes, ma'am.
So just tell whatever you remember. Don't see that. See the diagram and just tell whatever you remember.
5 into 6
Summarize.
5 into
Hmm.
6 centimeter mass globular swelling in the right subcostal region. Medial and lateral border is palpable. Move with respiration. And although the finger can insinuate subcostal region, uh, and swelling moves with the respiration.
So intrinsic mobility you will tell and movement with respiration. Okay, both you have to tell. Then
And other no visible sign, no skin appears to be normal, no visible no visible peristalsis, no sinus or any other skin changes. Scar or hernial orifice appears to be normal.
so the liver span is normal. Okay, enlarged liver is not enlarged. Okay,
No
there is a
organomegaly.
mass that is felt in the
Right
subcostal region.
hypochondrium.
Yeah, subcostal region, but separate from the liver margin. Okay, and it's globular, and here it is felt, but sometimes you might feel only on deep inspiration. Okay, and it's a non-tender swelling, right?
Hmm.
So with these findings, I could, I mean, I could directly tell it as gallbladder mass. Okay, so enlarged gallbladder mass, enlarged gallbladder. Okay, from your history and examination, what is your diagnosis? Differential diagnosis. Always in abdomen, differential diagnosis. Okay, don't tell one diagnosis.
Gallbladder mass
It's an enlarged gallbladder. Okay,
associated
so
with pain.
mm,
So it can be due to choledocholithiasis, but bile is not a.
Hey, what is Kurvoiser's law?
Courvoisier
you
law
cannot
in the
have
case
palpable
of
gallbladder.
jaundice, if gallbladder is palpable, then rarely it's due to gallstone.
Okay. So, how many gallstones you have seen with a palpable mass?
If neck of gallbladder, if the mucocele of gallbladder, empyema gallbladder, if for such conditions, if neck of gallbladder there is obstruction, then can be a palpable mass, or xanthogranulomatous cholecystitis is there, then it also mimic GB mass and malignancy.
Yeah, but not so common, right? Whatever you told, accepted, they can present with gallbladder mass, but they're not so common, right? So you cannot give xanthogranulomatous cholecystitis in your clinical diagnosis.
Because it's
Right?
a pathological diagnosis.
It's a pathological diagnosis. Yeah, impaction at the neck with distension of the gallbladder, mucocele are still possible. Okay. But
Empyema gallbladder.
in general, cholelithiasis may not present with a palpable gallbladder, right?
Yes, ma'am.
So, what are the exceptions to Kurvoiser's law?
Double stone, one in cystic duct and one in CBD, or and
Yes, others can help.
Mirizi syndrome.
Mirizi syndrome. वही तो.
Mirizi is different than Mirizi is different. Mirizi is
What
when
is
cystic
Mirizi
duct
syndrome?
stone. It is when the
neck of
cystic duct impinges on
gallbladder
CHD.
stone compressing CBD, and sometimes it stay it's formed cysto fistula also they are forming. उसका कुछ नाम
So it's an
है.
extensive compression, basically, right?
Yes.
So what else are the exceptions to Kurvoiser's law?
Hilar carcinoma.
Not exactly. Still something. Choledochal cyst is what?
Choledochal cyst.
It's not exception. What is choledochal cyst?
So, cystic swelling arising from the cystic duct or dilated cystic duct.
So it's one of
the cause of jaundice. OJ. Or a pain,
No.
cause of pain in right hypochondrium also.
Choledochal cyst congenital or acquired?
Usually congenital, but detected in early 25s and early age.
Yeah. So what is anomalous pancreaticobiliary duct junction anomalies?
Pancreas have two dorsal and ventral two buds in due.
Communication of the pancreatic duct with cystic duct at common apetic duct at a higher level.
So any anomaly in opening of the ducts, okay, so
is one of the
that
risk
might
factors.
lead to APBTJ. Okay, so now first of all, choledochal cyst is not an exception. Oriental cholangiohepatitis, you people heard of it? Then double
Oriental
impaction
is
of the stone.
Oriental is this only. That Chlorenchus sinensis, no?
Clonarchus sinensis. Yeah. So that's one. Okay, double impaction of that. Post surgery.
Previous
Gallbladder.
cholecystectomy in distal malignancy.
Yes. So these are the things. Okay. So now with your this one, if you have to give a differential diagnosis here in an order, okay, 3. What are the differential diagnosis you would like to give? Because whatever differential diagnosis you are giving now, based on that, we'll work up this case. You tell me.
No.
Okay,
no
you
DD.
can.
Only
Sorry?
one. No DD, only one.
No DD.
No, no,
You
no.
have to give DD. You have to give DD.
CAGB, palpable CAGB,
CAGB, if you
most
give as
common.
diagnosis, that is, they will not accept at any cost. Okay, so
CA,
you have to give DD. Any abdominal case, remember to give DD.
CA pancreas,
HCC.
HCC में CA GB क्यों बढ़ा हुआ रहेगा?
So there is distended gallbladder. What are causes of distended gallbladder? Palpable. Okay. Okay, one
Mucocele
is CAGB.
empyema, CA pancreas,
Okay.
periampullary CA, and CA gallbladder.
There can be any lymph node compressing on that.
उससे lymph node
Causing
should
distend-
compress CBD ना to cystic duct to cause any
it
lymph
can, no?
node.
Yeah. So these are all can be present, right? So
What are the palpatory findings? What are the margins, consistency?
Margin were irregular. Consistency
Can
was firm,
empyema,
not
mucocele,
hard.
it can be regular. And
that's why
consistency can
I
be
told
hard.
you. No, that's why I told you first diagnosis you can give as malignancy. After your confirmation, after your findings, irregular, firm mass, globular mass present in the gallbladder point can be mostly malignant. But still,
benign cases, smooth margins, firm consistency.
Yeah, you can give. See, they can be there, but first diagnosis will be malignant, but still you should give benign also. Okay,
I'm
because
seeing daily gallbladder mass, ma'am, but on palpation I can never be sure कि it's
yes, you have to confirm as an extension of your clinical examination. I would like to do an ultrasound to confirm my diagnosis, but at this point, with my clinical findings, I would like to give differential diagnosis. Most commonly with neoplasm malignant etiology as my first diagnosis. However, I would like to rule out the benign causes also. So if you tell like this, they will accept. Okay, I would like to do an ultrasound as an extension for my clinical examination. Okay, because my hand will not detect everything. So I may have felt it as irregular. I may have felt it as firm. Okay, but still, I would like to confirm my diagnosis with. I would like to do an ultrasound to confirm my diagnosis as an extension of clinical examination. But at this point, I will still give differential diagnosis. I will not give a single diagnosis. Okay.
Okay.
Right. So now next, what do you want to do?
I want to do clean USG for this case and basic hemogram and liver profile for this LFT.
Again, I'm telling you. I would like to do few investigations to confirm my diagnosis, to stage the disease and plan the management, right? So,
पर अभी तक तो हम लोग श्योर हुए नहीं है malignancy है.
Yeah, that's why you tell for extension of my clinical findings, to confirm my clinical findings, I will do as an extension of clinical examination, I'll do an ultrasound. So next question is, what are the things that you see in an ultrasound?
Origin of mass, that thickening of gallbladder, liver status, ascites, a regional lymph node if possible, and IHBRD dilatation.
Yes. So 10 are there. Okay, 10 things you have to tell in ultrasound.
10 things.
You told origin. You told nature of the mass you have to tell. Okay.
Nature of
hypoechoic mass. Okay. Then you told
liver condition, ascites, IHBRD.
See, पहले बोल gallbladder में क्या देखेगी? Okay.
Then to rule out gallstones and thickening status of the gallbladder.
Okay. Any other thing?
Any mass or thickening. दो ही चीजें देख पाऊंगी मैं.
और देखेगी, polyp देखेगी.
Polyp and mass.
हाँ, then
stones. And
wall
stones.
thickening you told. Any stones, yeah. And
And if it is stone, it is single or multiple, it is obstructing at the neck, or CBD dilated hair, it's there or not, or it's causing
Okay.
IHBRD dilatation,
Hmm. So
ascites.
IHBRD, CBD, pancreatic duct, okay, any hepatomegaly, any ascites, okay, any lymphadenopathy, periportal lymphadenopathy, then any signs of portal hypertension, okay, any
Portal
splenomegaly,
hypertension.
hmm, any splenomegaly. Very rarely omental nodules may be seen, but not on ultrasound very significantly. Okay, any collaterals to portal vein. Okay, any portal vein thrombosis. Okay, all this can be seen on ultrasound. Okay, so that's why ultrasound is very good modality as a first investigation in any cases of hepatobiliary or gallbladder specifically. Okay, then okay. So now discussing each point of ultrasound. So how do you see? You'll see the origin of the mass, right?
Yes.
Then you told wall thickening. So can you tell me something about wall thickening and the suspicion for benign or malignancy? What is the cutoffs?
More than 1 centimeter of
5 mm.
1 centimeter? No.
5 mm.
So first of all, whenever you see gallbladder wall thickening, okay, you will see whether it is focal or diffuse.
Asymmetric,
So,
focal or diffuse.
Yeah, first of all, focal or diffuse. If it is focal, what is the thickening? If it is diffuse, what is the thickening? Okay. So any focal thickening more than 4 mm or any diffuse thickening more than 7 mm. Okay. It will raise the suspicion. Okay. Anything more than 2 centimeters of gallbladder wall thickening almost always signifies it is due to malignant etiology. Okay. The gray zone is between 4 to 20. 20 mm. Okay. Right?
And polyp more than 1 centimeter.
Yeah. So, and if there is polyp with the gallstone, that is also suspicious. Okay. And you will see there is something called, like BIRADS, we have GB rads also. Okay. That is based on this thickening, whether it is circumferential thickening, whether it is focal thickening. There also in GB rads also you have this staging from 0 to 5. Okay. So when it is less than 3 mm, I think it is 0. And if it is focal thickening, it is 1. If it is less than 3 mm, it is 1. And if it is focal thickening, it is most probably it's benign cause and it is 2. And if it is circumferential thickening with no layering, it is 3. And if there is layering, then it is 4. And if there is loss of interface along with this thickening, conclusive of extramural invasion, it is 5. Okay, this is GB rats. Okay. And so that will tell you that interface, the mural thickening, and association with any polyp or any stone. All this can give you a gross idea whether it is due to any benign cause or malignant cause. But what is not seen on ultrasound is this peritoneal nodules. Okay. So the lymphadenopathy may not be very significantly seen as in CT. Okay, so that is about ultrasound. So what probe of ultrasound will you use?
High frequency.
Low frequency.
High frequency.
High frequency, low frequency.
What is this high and low?
For thyroid and all, we are using high frequency ultrasound. For breast also.
So 7.5 is enough. Okay. Here.
Higher low.
Here.
More than 12 is high. Okay. Then, so
superficial things, we use high frequency probe. To see deep things,
it is 7.
We have, and the curvilinear probe is
probe is enough. Okay.
Yes. Okay.
Yes. So now you have got a gross idea, Saumyta, that there is wall thickening. Okay. It's an hypoechoic mass. There are no calculi. Okay. There's no other dilatation of any other duct. Okay. And there is no IHBRD. Right. There's no features of any jaundice or stigmata of any liver disease with no portal hypertension. Okay. This was the finding on ultrasound. Next, what?
Then I would like to confirm my for staging the disease and confirmation of diagnosis. I would like to do imaging, CCT, thorax, abdomen, and pelvis, and blood investigations.
Okay. Do you want to add anything to CCT?
CCT.
Triphasic, I guess.
With contrast.
Triphasic we are not using for gallbladder. Matlab we if in
Contrast.
USG I am having ki is gallbladder mass, then I won't go for triphasic. I will go for triphasic if I am thinking it's arising from liver.
No, any hepatobiliary for the vessels for the planning the surgery. I think triphasic is.
What is triphasic?
Portal venous phase, arterial phase, and another phase is
Okay, arterial, portal, and venous.
So, does this have any significance when it comes to the, you want to see the gallbladder? Don't you want to see the vascularity?
in liver, ma'am, it's for diagnosis. Arterial enhancement and venous washout is one of the characteristic finding of the liver disease.
That's fine. I'm not asking about liver.
But
In
for
GB, what all you want
gallbladder,
to see?
I'm not aware if is
Okay,
there any.
let me ask you the other way. What all you want to see on CCT in case of gallbladder?
I want to see the liver gallbladder mass infiltrating liver according to the size, liver infiltration
So what
depth.
all you have seen on ultrasound, you will see on CT also. Okay, all the wall thickening, polyps, okay, the ducts and all. In addition to that, what is specifically seen
Lymph nodes
very well
and
on
distant mets.
and something else, right? Which will matter your
Para-aortic
which will
lymph
matter
node.
to you. Okay. What is the staging for gallbladder cancer?
T1 T1 A is lamina propria, T1B is muscle involvement, T2 if it is A invading peritoneal side of and T2B peritoneal side of liver, and parenchyma involvement or any of the other organ involvement. One organ is T3 and more than one organ is or vessels involvement is T4.
So can you see the interface on CT?
Yes,
Okay.
yes,
Better than ultrasound? Right?
yes,
So that is one. You can see the momentum?
yes, momentum.
You can see. You can see the vascularity?
Vascularity, yes, ma'am, it can, we can, but that vascularity we can see in
So you heard of some resection techniques in gallbladder, no? So other than wedge resection, the Miyazaki techniques and all, did you hear?
Miyazaki, no, ma'am, not heard.
No.
So whenever we dissect 4B and 5, isolation and all, we see the portal pedicles, okay, posterior portal pedicle and all. So to delineate the vascularity clearly, that is relation of right hepatic artery, common hepatic, portal vein, okay? For this, we use the triple phase, okay? Other than that, CECT in early cases might suffice. But when you want to do the
Radical surgery,
extensive resection, radical surgeries, then always get a triple phase CECT. Okay. You also see the biliary infiltration to any the side of the liver. Okay, other than because it upstages, no? If it's not onto the peritoneal side, it's onto. Why is it so? Why this has been given like A and B? Has it got any significance, and why is it so that onto the side of hepatic side, it is given a more stage compared to that of peritoneal side?
Prognosis.
There is a reason. It is related to anatomy.
That can also lead to the regional spread because of the direct.
What is absent on
Hilar plate.
So there is direct venous involvement directly from the GB through the hepatic blood vessels. So from there it can lead to a spread as well. So that is also one of the way of local spread.
Systemic spread.
So there is what are the ways of spread of gallbladder CA to the liver?
Direct infiltration or hematogenous systemic mets.
So once she told venous, then direct, then
Hematogenous, that multiple liver mets मैम जैसे होता है.
okay. Can it be through the lymph nodes, retrograde spread?
Lymph nodes.
It can be. Okay. So these are all the things that it can spread to the gallbladder. Okay, ways through which it can spread to the gallbladder. So what are the lymph nodal stations you are interested in, Saumyta, when you are concerned about GB cancers? What are the lymph nodes you are looking for? Stations?
Periportal lymph node and retropancreatic lymph node, level 8 common hepatic artery lymph node. These all are resectable lymph node stations, but if it's a para-aortic lymph nodes, it's a metastatic. So if para-aortic lymph node enlarged, then we should consider it metastatic and patient will go for palliative treatment.
Okay, suppose you are seeing para-aortic lymph node on CT. Okay. So you are seeing it is less than it's 1 centimeter around. Okay. Not showing so many signs of like metastatic lymph node. So how do you like to proceed in that case?
In benefit of doubt, we will go for staging laparotomy, ma'am.
Diagnostic lab
Diagnostic lab, we usually don't go for reach para-aortic region in our setting.
No. You can do it.
Biopsy of the lymph node.
No, I think we will just after opening up the abdomen and excluding any general meds, we'll just do a cauterization and then just do a biopsy, a frozen section of those two nodes. If they are negative, we proceed with the surgery. If they're positive, then it is deemed stage 4 and we consider it to be
that cannot be done by laparoscopy, no? It's laparotomy only.
No, it is done by laparoscopy, but it can be done. But in our setting, we are doing by laparotomy only. But it's not that it cannot be done by laparoscopy.
It can be done by laparoscopy. Can be done. Okay.
But we can do the in our setting we are doing by laparotomy. That's it.
Okay, but the main thing is that you will send it for frozen section, and if it comes as positive, we'll abandon. Okay.
So I have one question here, ma'am. What if that frozen section node shows only micromets and macromets? How do we proceed?
Even if it is micromet, we don't proceed. Okay, because para-aortic lymph node involvement itself is in present situation they are giving NACT and reassessing the para-aortic. They are considering it to be curable disease. Okay, but it's still not operable upfront setting. Okay, whenever it comes positive, even in presence of micromets, you'll abandon the surgery because gallbladder cancers are quite aggressive. Okay, so once you treat in some studies, they have told that they treat it on curative basis, even if it is 16B lymph node is positive. Okay, giving NACT if that is the only site of metastasis. Okay, if there are other metastases, you will treat it only with palliative. Understood? So that is the thing. Okay. Other than that, any importance of where do you go up to when you clear the lymph nodes in the radical coli?
We start from periportal and retropancreatic lymph node, and from level 8A we remove. Then we come to pituitary ligament, and
That is one.
from there we go up to the full right hepatic artery and left hepatic artery and portal vein, and cystic peridococystic gallbladder we are removing along with that cystic nodes.
Yeah,
Station
what you
8,
told
12
is
and
correct,
13.
but sorry.
8, 12 and 13.
Yes, 8, 12 and 13. So your limit of dissection will be the left gastric. Beyond that, you won't go. 8, 12 and 13 will be removed. Okay. So onto the right side, onto the left side. So you don't go beyond the area of the left gastric drainage. Okay. So that first, anytime first is 16B. Okay. After ruling out 16B only, then only you will proceed with all the things. Okay.
Yes, ma'am.
So okay, next. So that is about CT done. Anything else you want to do? Any blood investigations?
I would like to do basic hemogram, LFT, and tumor markers, serum CEA and CA19-9.
Yeah. Can you tell me something about CEA, CA19-9?
For serum CEA is a more specific than CA19-9 for CAGB, and CA19-9 is more sensitive for pancreatic mass rather than CAGB. And
Yeah, you are right.
if CEA level is elevated, its prognosis is, means we can go to, it's also an indication of malignancy, and we can do our routine follow-up post-op setting by monitoring these markers. And
Okay.
if CA19-9 is elevated above 1000 or 500 or 1000, CA19-9.
Yeah, 500 it is. They're as per 2017 guidelines. Okay. So more than 500, it is more so malignant rather than benign. Okay. That too, you will see these all markers in patients who are it's a non-obstructive symptom, non-jaundice symptom. Okay, in jaundice patient, it has no relevance. Only after biliary decompression, these markers are significant. Okay. So, they are diagnostic or prognostic markers?
These are prognostic markers.
They're both. Okay. So, but other than that, anything else you want to say? LFT you told. What in LFT?
LFT, ma'am, just to rule out jaundice or any obstructive features are present, and PTINR one of the important role because if deranged PTINR is there, so we cannot take patient for the surgery.
Okay. What are the features in LFT? I mean, what are the tests in LFT that point towards obstructive jaundice pathology compared to normal?
Increase alkaline phosphatase and direct bilirubin level more than 3 times of indirect bilirubin level, and increase gamma glutamyl transferase.
Yes. Gamma GT 5-nucleotide if it is increased. Okay. And as you told, bilirubin.
Direct bilirubin is more than indirect bilirubin.
Yes. Anything else you want to see in alk-phos? Okay. Alk-phos also is important. And anything else you want to see in LFT?
PTINR, it's also gave.
Anything else?
Albumin and proteins.
Yeah, albumin. Okay, it is more important, especially for surgeons. Okay, so albumin is important. Then what else? CEA you told. Okay, so CEA is more sensitive or specific?
Specific.
Yeah, it is specific. Can you tell me how much sensitive, how much specific?
70% approx, not sure, ma'am.
So CEA is almost 92.7%, 93% specificity. Okay, but sensitivity is very low, around 50%. Okay, CA 99 has sensitivity of around 80% and specificity is also 80%. Okay, so that's how. Will you do an FNAC, Saumyta?
By imaging, it seems to be operable. Then I will like to do diagnostic laparoscopy. Should not go for FNAC. If in case inoperable or locally advanced CA gallbladder, in which and neoadjuvant therapy is indicated.
Yes. When you want to give NSCT or when it is metastatic already. So you want to prove it that it is CAGB, then only you'll do. Otherwise, though there are some studies, but the incidence of tumor seedling is less than 1%. Okay, so yeah. Then so other reason why peritoneal and hepatic sites are divided like that. Once she told there is no covering, so when whichever goes onto the hepatic side, no, there will be direct infiltration and venous spread compared to the peritoneal side. So hepatic has worse prognosis than peritoneal side. Okay. So what is T3?
T3, ma'am, liver infiltration, parenchymal infiltration, or single organ duodenal or
what is
colon.
which layer is not there in gallbladder?
Yes, ma'am.
Which layer is not there in gallbladder?
Submucosa.
हाँ, sorry.
Lamina propria के बाद डायरेक्ट मसल आया था.
So what is not there?
Submucosa.
Correct. Submucosa is not. Okay. So if it is hepatic artery or portal vein involvement, which T stage it is?
Hepatic artery and portal vein T4, ma'am.
Yeah. And what about the lymph nodes?
Lymph nodes 1 to 3 is N1 and more than 3 is N2. And para-aortic is M1.
Yeah, para-aortic is M1. Okay. So next, what other investigations you want to do? Any role of PET CT?
In upfront setting, in our center, we usually don't do PET scan, ma'am.
No. Not in your center. Any role of PET CT?
Role of PET CT mostly in incidental CAGB.
Very good. Next.
Or after NACT, if for patient evaluation, but we usually do
residual tumor. Then, if you have extrahepatic mets?
Extrahepatic mets, if diagnosed on CCT, then we don't go for PET.
Yeah. So if it is inconclusive, still you can do PET. PET upstages in how many percentage?
30%.
No. 17% approximately. Okay.
Okay.
And if it is, means it differs if it is locally advanced gallbladder cancer, if it is not positive or it is not negative. Okay. So it will give additional findings in around 30%. Okay. It changes management in 23%. Okay. It upstages the disease in 17%. In locally advanced cases, not metastatic, I'm not talking about metastatic. If it is in locally advanced GBs, it might upstage up to 34%. Okay. So, and if it is not positive, up to 27% can be upstaged.
Which paper, which evidence we have to quote for this?
This is अरे वो हमारा NB class लिया था ना, Shivendra Singh et al. Okay.
Okay.
So, what is sensitivity and specificity of PET for GP cancers?
Sensitivity was low, ma'am, but specificity was high.
That's why it's not used, right?
Sensitivity is around 56% only, but specificity was around 80%, I think. This I read from EBM.
Sensitivity is around 70%, specificity is around 85%. Okay. And diagnostic accuracy is 80%. Okay. False positives are around 7.4. Okay. So 7%. almost. Especially it is good when it is metastatic disease rather than any localized evaluation. Okay. Anything else? MRI?
If CAGB presents with obstructive jaundice, in that condition, I would like to go for MRI with MRCP.
Obstructive jaundice. Okay. Then, how do you see the lesion in MRI? Like whether it is visible on T2, T1, how is it visible?
It should be visible on
What do
T1
you compare
images,
it to?
ma'am. T1 images. Because
It is hypointense on T1, hyperintense with heterogeneous enhancement on T2. Okay. Whereas this all things are compared to what what is the intensity compared to?
bile.
Liver parenchyma.
Liver parenchyma. Correct. Yeah. So what about other things you see on MRI? Well, compared to CT.
Cystic CBD obstruction under which CBD, which level in the CBD we can see clearly in the MRI as compared to CT.
Okay, so you see the ducts come nicely. Okay, the peritoneal, the ducts, all bile ducts. Okay, you can see the vessels properly. You can see the infiltration to surrounding organs, either duodenum or any liver infiltration or any peritoneal infiltration. You can see better. Okay, and any biliary obstruction, as you told, we can see better. Okay, based on that, again there are levels of block. Okay. So, what is the sensitivity of MRI for the ducts and vascularity? Is almost 100%. Okay. So, when you want to see the ducts, biliary ductal anatomy or vascular anatomy, MRI is the investigation of choice. Okay. But when it comes to lymph nodes, it has less sensitivity than that of CT. Okay. It's around 60 to 70%. Okay. Right.
Okay.
Then, yeah. So that's about the investigations, right? Then what else? Other things. So staging lab is also one staging investigation. So
before proceeding for any surgery, we usually go for staging laparoscopy.
So what is the upstaging and staging laparoscopy?
30%.
So upstaging by PET is 17%. Okay.
Yes.
17 to 30%, depending upon which stage nodal involvement is there or not. But an upstaging by lap is?
It's also 30%, ma'am.
No, 23%. Okay. 23%. Agarwal et al.
Agarwal et al. Okay.
So what do you want to see in a staging lab?
Any peritoneal nodules, omental nodules.
Yeah. So generalized deposits. Next. Liver metastasis.
Liver metastasis.
Ascitic fluid?
Ascites usually ascites we have to see, but usually ascites is absent. If preclinical or pre-op ascites is peritoneum deposit, omental deposit is a bowl there.
So what is the importance of peritoneal fluid cytology in CAGB?
CAGB, ma'am, no idea, because CA stomach we usually do, not CAGB.
Suppose peritoneal fluid is positive.
So it's a malignant metastasis.
So do they do, it's a metastasis. So they do bad. Okay, whenever upfront peritoneal fluid cytology is positive, they do bad. So though in stomach, they take it for NACT, reduce and do it, but in general, the prognosis of those who present with upfront peritoneal fluid cytology, it is bad. Okay. Rather than the solid organ deposits, omental deposits, if the peritoneal fluid cytology is coming positive, they do more bad than those who are presenting with the deposits over the organs. Okay. So, yeah. So, that's about staging investigations. So what about next? How do you want to manage? You finished confirmation of diagnosis, staging investigations. Now come to management plan.
I would like to do extended radical cholecystectomy. Radical cholecystectomy for this patient.
Okay. So you want to do minimally invasive, you want to do open.
I would like to do open radical cholecystectomy.
Yeah. You don't want to do staging lab?
Staging lab कर लिया ना मैम.
You have to tell. Okay. So how do you manage patient means staging lab, then rule out metastasis and then proceed with laparotomy. Okay. Then again look for metastasis. If 16B is positive, I'll send it for frozen. Then proceed. If there is no evidence of any metastasis, I will assess. After assessing the resectability, I'll proceed with radical cholecystectomy with clearance of lymph node levels of 8, 12, and 13. Okay. Or radical cholecystectomy, I'll do wedge resection or segmental resection, whatever you can say.
We usually do wedge resection.
Yeah. So both are equal. Okay. They're long-term studies. Okay, we'll discuss about that. Okay. So yeah. So now, what are the steps of radical cholecystectomy? First, you tell me what are types of presentations of CA gallbladder?
Types of presentation.
Yeah.
Incidental.
Yeah, incidental is one. Then overt CA gallbladder, unsuspected CA gallbladder, right?
Okay.
In overt CA gallbladder, you have again early, locally advanced, and metastatic. Okay. In unsuspected, unsuspected with what? What is unsuspected gallbladder?
Unsuspected means you intra-op you detected. Correct. You had planned a simple cholecystectomy and intra-op you detected.
See something fishy there. Okay, so then you think it is CA gallbladder. That is called unsuspected CA gallbladder.
And incidental means you have full operated and final histopath you got CAGB. Correct.
So these are three modes of presentations of CA gallbladder. Okay. So can you tell me types of histopathological types of CA gallbladder? Since you told incidental is through only histopathology.
Adenocarcinoma, most common type of histology which we usually get.
Papillary, nodular, infiltrative.
Yeah, nodular.
Papillary, infiltrative.
Papillary. Which has got best prognosis?
Papillary.
Yeah, papillary. So, if suppose CAGB present with jaundice, Saumyta, so what is the reasons for like jaundice in CAGB?
First of all, a stone obstructing neck along in the neck or mass in the neck which obstructing gallbladder patient can present with jaundice or it's infiltrating
I'm asking CAGB. Okay.
Gallbladder mass, in neck of the gallbladder mass can be also there, na?
Yes, neck of gallbladder mass. Okay, CBD infiltration or direct infiltration or through lymph nodal infiltration.
No, lymph node obstructing.
Yeah, lymph node either through extrinsic compression or direct tumor infiltration. Okay, or why I'm asking this question here because Mohan told papillary. Okay, if papillary type of growth grows into the neck of the gallbladder, that also can present with jaundice. Okay, so that's why that's presentations for jaundice. Yeah, coming back to this one. So HP you told. So which has got worst prognosis?
Infiltrative.
What is the most common presentation here? I mean, most common histopathological type?
The papillary is most common.
ऐसा वो कभी लिख के नहीं देता है मैम.
No.
Adenocarcinoma ही they are writing.
Unfortunately is not common. Okay. Papillary unfortunately is not common.
Infiltrative is most common.
Infiltrative is most common and it has worse prognosis. That's why CAGBs are have worse prognosis.
But
Okay.
ma'am, they never
If
write
it-
this on a histopathology report, infiltrative and this nodular. And in our
Well, they
settings,
do.
they never write.
No, they do. Okay, suppose there has come one patient has come to you, Saumyta.
Yes, ma'am.
Lab poly done.
Hmm.
So he brought the histopathology report. So what all you want to see in histopathology report?
First of all, I want to see what where muscle T1A or T more than T1A or T1B, matlab which layer it's involved, margins are free or not, and cystic duct margin is most important. And if simple cholecystectomy done means lymph node is not addressed. So more than T1A, if any person is coming to us, we should go for completion cholecystectomy. But before that, we should evaluate with the imaging. If patient is coming to us less than 4 weeks, then we will go for CCT, thorax, abdomen, pelvis. If a patient comes after 4 weeks to us, then we will go for PET scan.
So suppose patient today is what day? First. So suppose patient had undergone a lab chole on 27th. Okay. And the report has come and he has come to you. And it shows the gallbladder is in T1A stage, first case scenario. What do you want to do?
In final histopath, ma'am, it was T1A.
Yeah, final histopath, it is T1A. No lymph, the cystic duct margin is negative. So
then for this patient, we can observe.
Okay. Next, T1B.
For T1B, we will go for completion radical cholecystectomy.
How early you want to go? Before that, first, do you want to do any metastatic workup?
PET scan we will do, ma'am. PET scan or...
You have to tell. So, since it has been approved as CAGP, so I would like to do a metastatic workup in your case to see for any evidence of any distant metastasis. Okay? Since this has come as T1B, the chances of
lymph node metastasis is more than 25%.
So, I would like to do a completion radical cholecystectomy in your case. Okay? So, that's how you have to tell. Then, so, yeah, anything about T1B? Mandates a resection, right? So, now...
but if in case residual disease is seen on the PET scan, then according to TMH criteria, that patient should go for NACT.
Yeah, NACT we'll discuss. First, we'll finish off this surgical management, then we'll discuss NACT. Okay. So, how do you proceed with the... So, how early can you do a surgery in an incidental gallbladder?
Madam, just like to ask, even for T1A, I think we will still do a staging workup if the patient comes after a laparoscopic cholecystectomy to us. Is the staging workup still indicated in T1A also? Even if
what is the incidence of lymph nodal metastasis, or what is the incidence of distant metastasis in T1A? That will answer your question.
T1A means I think less than 3% or 5%.
Less than 5%.
5%.
Yeah. So it will not
mandate. We will say like this ki if a proper in our Bihar, it's like if, how they remove the sample. This gallbladder.
Port site metastasis एक rule out करना है, क्योंकि laparoscopic में किया है तो once the pneumopred actually the port site, if they have port site metastasis, they do bad. Okay, whatever it is. So resection of port site metastasis in long term, this one has not added to any benefit of overall survival.
If bile spillage and all, its OT notes is not properly mentioned, everything.
First, you would like to consult the surgeon who has removed the gallbladder. What way he has removed? Was there any spillage? Okay, all these are negative. It was a clear-cut, clean cholecystectomy. Okay, removed in a bag and all. Then it's not indicated. If there was any if it is not documented or the surgeon you could not contact, then you do evaluate. Okay.
Yes,
So,
ma'am.
but the incident, having informed the patient that the chances of locoregional or distant metastasis is very less. Still, I would like, since your OT notes is not available and I could not contact the surgeon who has operated, so I would still like to do a workup here in this case. Okay. If everything is available, the incidence is very low. Okay. Not much indicated. Okay. Incidental gallbladder cancers में एक modality is that you have to do metastatic workup. It is more than T1B. Okay. T1A you can observe. Okay. So yeah. So we are talking about radical cholecystectomy. What is radical? What is extended cholecystectomy, Saumyta?
Along with gallbladder and periportal lymph node and wedge resection of liver, if we are doing this resection, anything extra than
is
this?
There any difference? First, is there any difference, or it is the same? The term radical and extended, are they different, or is it the same?
Any extra segment, ma'am, we are removing, or any extra structure we are removing more than radical cholecystectomy, then it's called extended.
No, both are the same. Okay. There is what you are talking about is extrahepatic bile duct resection. Okay, that is different. Okay, both are same. Radical chole and extended chole are same. Okay, they are used in by different people in different way, but the meaning is same. Okay, radical chole or extended chole. So what is addition? Why it is called radical?
Because along with gallbladder we are removing liver
and
periportal lymph nodes, regional lymph nodes.
Okay. So now coming to so what is wedge resection? What is 4B5 resection? And what are the advantages and disadvantages of the same? Do they actually change the overall survival or disease-free survival? If you anything has in long-term studies, was there any difference?
Long-term studies both shows no difference in overall survival and complication rates are more in wedge resection. Means after induration 1 centimeter extra we are taking.
2 centimeters.
2 centimeters.
Two. Okay, not 1. Yeah. Okay. So 4B and 5?
4B5 segment if we are removing from vascular pedicle, which we usually have not seen yet. We usually
so
don't.
What will the in see it all amounts to the extent of resection. Okay, in long term, the wedge resection or this 4B5 segmental resection have no much differences in overall survival or disease-free survival. Okay, so but with when you do wedge resection, no, that same thickness of removal will not be maintained. Okay, so suppose you have to remove the 2 centimeters margin. So measuring that 2 centimeters, not everyone will remove. Okay, they'll just remove that some part of liver what is adherent to that gallbladder bed and call it wedge resection. So that is the problem. Okay, and there might be increased bleeding, bile leak. Okay, with the extent of resection. True wedge resection will not be done by many of the surgeons. Okay, so that will have margin of 2 centimeters. When 4B5 segments are removed, almost 3.5 centimeters you will get. Okay, from 1.5 centimeters to 3.5 centimeters margin you will get. And if you do extrahepatic resection, then you'll get up to 5.8 centimeters margin. Okay, so this is the difference. So now, yeah. So wedge resection and extra. Okay, what are the indications for extrahepatic resections, biliary duct resections?
Cystic duct margin is positive. or if or it's below clad skin, below hilum, if it is disease is present, then we can do extrahepatic biliary tract excision.
Dense lymph nodes around the CBD and also thickening causing CBD, which compromises vascularity in future.
Lymph node compression, and we cannot remove the lymph node, or if we are removing the lymph node, vascular compromise.
As a part of lymph nodal clearance, if it mandates the bile duct resections, then you'll do it, okay? Or hepatic duct, this one. What modality you can use for doing a 4B5 resection? What are the things, like additional things that will guide you to do a 4B5 resection?
More than
something
more than 2 centimeter liver infiltration.
You will not know that this is 4B, this is 5, right? So there
Yes.
should be some guidance. So what are those?
Middle hepatic vein and falciform ligament, left hepatic vein.
Mainly both Cantley's line.
ICG can be used.
ICG can be used, correct. Then I told you something in the starting, no? Miyazaki technique. Have you
Vascular
heard
ligation. Vascular ligation करके we will it. मतलब clamp
So we
करके
clamp
ligation
the
नहीं.
right posterior pedicle and Ruvier sulcus. Okay.
Ruvier
So
sulcus.
and this one you can use intraoperative ultrasound, right?
Okay.
So segment 5 pedicle को अगर ligate किया है तो intraparenchymally, that is called Gleasonian approach. So these are few approaches that will guide. And she told, no, ICG is one of the thing. Intraoperative ultrasound guidance is the other thing. Okay, occlusion of the segment 5 pedicle. These all are things that will help us to delineate 4B5 segments. And basically there was no overall survival difference between either of these, wedge resection or 4B5 segmental resection, but the complications were more when there was 4B5 segmental resections. Okay, so it should be done in a safe hands. And following all this,
any specific indications for 4B5?
So if it is infiltrating, so if you see on table, if you think that it is infiltrating the liver bed, okay, the gallbladder bed, okay, so it is better to do the anatomical resection compared to wedge resection, okay. So you will be more safe because you will get more margin in that case. And there were few studies which told that in case of 4B5 segments, because you go as per anatomical this one, and then you give more margin, there will be more disease-free survival. But it was only in few studies, but majority of studies, there was no difference in overall survival. That is the down. You can do either way, but if there is frank infiltration or anything, better to do 4B5. Okay. So if it is T1 wedge resection, you can do T1B. If it is T2 or above, then 4B5 will be more better. Okay. There was, I don't remember the name of the study, but it was some Japanese study, okay, which told about all this. Okay. Then there was no difference in, getting a margin with early disease with 2 centimeters or more than 2 centimeters. Okay. So the overall survival remained same. Okay, that's about 4B5. Now come to, what is the route through which this why 4B5, how they will be infiltrated? Venous route. Most common is venous route. Okay. So 96% are through the veins of the gallbladder. Okay. There might be some like infiltration of the portal branches also. Okay. And next is in T2A, most common method is through the cystic veins, whereas in T2B and all, it will be through the portal route. Okay. And next is lymph nodes. Yeah. Tell me how how the lymph nodes are involved in gallbladder cancer.
How the lymph nodes?
4 pathways.
Yeah, correct. Tell.
I don't remember, ma'am.
One is angiolymphatic invasion. Okay. So venous invasion, whatever they run along that, and they'll spread to that hematogenous route. One is retrograde fashion from the portal lymphatics from liver side. Okay. So and other thing is through the one is through the hepatic infiltration, and another one is through the portal tract. So 3 things.
Venous,
Venous, retrograde
angio-invasion,
fashion from the liver,
angio-invasion,
and
portal.
correct way of it. Okay, so then what about we discussed what is the mode of infiltration of liver. We discussed one is either there are 3
Direct
methods by which
infiltration and venous.
direct infiltration, correct? Yeah.
Venous
Next,
and hematogenous, I told.
yes, correct.
And biliary, I think.
Whether it is-
Biliary also.
One is expansive. One is expansive type of infiltration. Okay. Hepatic spread. One is the hepatic spread with infiltration with contiguous pattern, or in hepatic spread or infiltration with discontinuous pattern. Okay. These are the 3 things. So what are the minimum number of lymph nodes that are dissected in BB cancer, Saumyta?
6.
Yeah. Okay. So anything cystic duct margin is okay. So cystic duct margin you will send for frozen, right?
1 minute, ma'am. Phone from hospital. Hello. Yes, sir. Yes, ma'am.
You're back, Saumyta?
Yes, ma'am.
Okay. So I was asking what is the survival with the T stages, okay, without with N0 or with N plus, what is the survival in GB cancers?
N0 and N plus. N plus it's a stage 3 and N0 is stage 2. For stage 2, ma'am, it's survival like 50% around. Okay.
With stage 3?
Stage 3, 30%.
Yeah, 30 to 40%. And stage 4, it's almost no survival. Okay.
5 years.
And in stage T1A N0. Okay. You almost get 80% survival. Okay. So 5 years survival if you take. Okay. Generally, gallbladder and hepatobiliary, they take more of 3 years survival because they do bad. Okay. Than 5 years. Then. So we did discuss resections, ICG. Yeah. What is Cantil's line?
Line joining from IVC to the border of medial border of gallbladder. Or medial kya?
Oh. So what's its importance?
It's divide in left and right side of the liver. Anatomical.
It has a loose areolar tissue along that line through which if you're planning a hepatectomy or anything, we can just do a hanging master.
Correct. So how do you divide this 5, 6, 7, 8?
5, 6, 7, 8.
So generally, to divide any segments, as per anatomical resection, you look at the veins. Okay. So where is right hepatic vein, middle hepatic vein, and where is the left hepatic vein? So we are talking about right side. Leave the left side. We'll discuss in liver. So you will identify the right posterior pedicle. Okay. And the right hepatic vein. Okay. So 5 नीचे है, उसके बाजू 6 है. Okay. What are the segments I'm talking about?
Right.
Right
5,
side.
6, 7, right. hepatic.
Yeah, what is the name of this classification? Or what are the segment?
Bismuth classification, Cunard classification.
Conards. Okay. So 5, 6, 7, 8. So on to the right side of the right hepatic vein will be 6, 7. Okay. On to the left side of it you will find the right posterior pedicle. So if you the area that is between this right hepatic vein and right posterior pedicle will be the segment 5. Okay, below. You're getting my point?
एक्चुअली सर से थोड़ा डांट पड़ा है मेरा दिमाग से थोड़ा डेविएट मेरे पेशेंट को काइल लीक हो गया है. So he is saying why you have started octreotide in such a high dose without my permission.
Okay. So right posterior segment किसका है मैडम? भूल गया.
Right posterior होगा
portal vein.
Portal vein.
7
so,
and 8.
What is medial lateral? What is anterior posterior? Tell me something about Conard segments here.
Conard segment divided according to that upper and lower will be divided by the portal vein and vertical lines drawn on the basis of hepatic vein.
Okay.
So middle hepatic vein, right hepatic vein and left hepatic vein. And for upper.
So अगर तुझे 5 segment identify करना है, you only told, no? The above one is the portal vein identification, and the lateral side of it will be the right hepatic vein. And the medial side of it will be the posterior pedicle. Okay, so that's how you isolate the 5 segment 5. Okay, so then you will also identify this Ruvier sulcus, okay, and hyla plates. Okay, these are the some techniques. See, if I tell it in theoretical way, probably you'll understand it better. Less. So you see, you type what is Miyazaki technique. Okay, they'll show it in they'll show it intraoperatively how it looks. So that way you'll understand better. If I tell it in theory, maybe that much of understanding won't be there. So just write Miyazaki technique kya hai. Okay, what is Gleasonian approach? So these are the some approaches to gallbladder resection surgeries for liver. Okay. Other technique to see any cystic artery. Tell.
Miyazaki is for segment 4B, right?
Yes. Segment 4B, 5 resections. Okay. So you'll clamp the right posterior pedicle in Ruvier sulcus.
Yes.
Okay.
Yeah.
That is Gleasonian is for segment 5. So intraparenchymal approach that is. Okay. And yeah. So yeah. What was that? Another one is that you can use methylene blue to identify the cystic artery. Okay. So for ligation and yeah, ICG Dishita ne bola shayad na.
Yes.
So tell me, Dishita, what is the ICG washout that you will consider for major liver resections, minor resections, and to present the functional liver residue? What is the cutoff?
So the ICG, the main excretion of the ICG is through the bile. So that principle is being utilized. So roughly around 10 to 20 minutes after injection of the ICG, we see measure how much is the retention of ICG in the liver. If it should be less than 10% in 15 minutes.
Less than 15%. 15 to 20%. Okay, less than 15%, 15 to 20 minutes. If it is less than 15%, at end of 15 minutes, you can do a major resection. Okay. If it is between 15 to 20, if it is between 15 to 20, you can do a minor resection. Okay. If it is less than 15, then functional liver assessment has to be done. Okay. Generally, they this one what remnant liver volume is calculated. Okay.
Yes.
So, what is the remnant liver volume that you generally prefer to do a resection? More than
25% in a normal liver. 20 to 25%. If it is post chemotherapy, then it is 30%. Post in a cirrhosis patient, it is 40%.
Correct. Correct. You are correct. Okay. To do a portal vein embolization,
Portal vein embolization, it should be at least 25 to 30%.
in a normal person, it should be 40 in those with cirrhosis. Okay. So, yeah. Now coming to, so we have discussed incidental gallbladder. Okay, we have discussed T2 from T2B. Okay, and T3. So we have discussed surgical pattern. Now, what are indications for NACT? Saumyta?
Yes, ma'am.
Saumyta,
More
forget. Don't worry.
than
That
2
these are common
centimeter liver infiltration. More than 2 centimeter liver infiltration, multiple enlarged lymph nodes, and if
So you're
any.
telling the TMS criteria.
Yes, ma'am.
Yeah, tell.
And vascular pedicle less than 180-degree involvement of the vascular pedicle, common hepatic artery, and any residual disease after PET scan.
So to simplify and tell, it is T3, T4 disease. Okay.
Yes, ma'am.
With contiguous liver involvement more than 2 centimeters. Okay. And any adjacent organ involvement. Okay. Be it stomach, duodenum, or hepatic site. Okay. Any hilar involvement. Okay. So this is about the anatomical part. What the nodal positivity? Any nodal positivity is indication for
But we are more than 2 centimeter single node we are not sending, ma'am. If it's 1 centimeter, more than 2 bulky lymph node is there, then
No,
only we
more
are
than 1
sending.
centimeter only is significant. Okay. Somebody's background voice is coming, ma. So please mute, na. Okay. Then other than that, what you told, less than 180 degrees common hepatic artery involvement or main portal vein involvement, either right or left. Okay. And T4 with T, that is T4, no? So any vascular involvement. And obviously for incidental gallbladder with residual mass. Okay, which you told already. Then these are the borderline resectability. So other than TMH, was there any studies which told about this borderline resectability and NACT?
I don't know, ma'am.
There were studies from Rajiv Gandhi also. Okay. There were studies from Rajiv Gandhi which defined as borderline resectability. They also more or less gave the same criteria with addition of few criteria like extrahepatic infiltration more than 2 segments. Okay. N2 disease, bulky lymph nodal disease. And if it is post-portal vein embolization in the waiting period, they have also proposed these criteria to give NACT. Apart from those which were proposed by Tata people. Okay. So what was the advantage? Okay, what is the chemotherapy you give? And how many cycles you give?
Usually we give 3 cycles of gemcitabine and cisplatin, and then again do the work, response assessment. If response is good, then we go for completion radical cholecystectomy. If response is not that operability, then we complete the full cycle, 6 cycles of gemcitabine and cisplatin, and again we do response assessment.
What are the advantages of giving NACT?
Downstaging the disease and decrease its preserve it's extra extended surgeries like CBD resection and vascular resections all can be
So if I ask you, tell me the most important prognostic factor in case of gallbladder cancer for surgical resection.
R0 resection and
very good, R0 resection. Okay, here all things of giving NACT and all will revolve around this R0 resection, because 5-year survival will depend upon R0 resection. Those without R0, okay, they will have only some 24 months, means 2 years survival post. If they are advanced and we could not do an R0 resection, then they'll have hardly 24 months survival. Otherwise, they will have up to 5 years, 60 months. So 47% was the people benefit of R0 resection. So it's all revolving around this R0 resection, which plays an important role. And also the incidence of bile leaks. Okay, so most common cause of morbidity is a bile leak. So suppose cystic duct, I'll ask you the complications. Okay, so that was one which could be tackled with. Okay, and they have told in this TMH study that there was those who were given NACT and then resection was done. This one was 49 months compared to those who were operated, who after only 7 months. Okay, with that stage of the disease. Okay, and even RGC, I mean Rajiv Gandhi also, they have proved that those who have responded to this NACT, okay, so complete response was not there in anyone, whereas the partial response was there in around 80% of people. Okay, and there was some stable disease in couple of people and progression in one. So this was the R0 Rajiv Gandhi study. Okay, so overall survival is better with good R0 resection post NACT is what they have concluded. Okay, so their additional criteria what they took was
bulky node,
extrahepatic infiltration along with bulky disease and waiting time period for portal vein embolization. Okay, so suppose they present with jaundice. Okay, so do you want to drain if you want to drain? Okay,
yes ma'am, ERCP should be done.
So which do you prefer, ma? Like suppose PTBD or ERCP?
ERCP should be preferred if possible. But if it is not feasible or sometimes duodenal obstruction in any advanced disease, then we can go for PTBD also.
Yeah, so it improves the overall outcomes. Okay, but however they do bad. Okay, if it mandates a PTBD, then they do bad. Okay, so 3-year survival in those who present with this kind of jaundice and all. Why it is more concerned is that they'll have cholestatic liver. Okay, so that's why initially they told that those who present with gallbladder with jaundice, then they are almost advanced and inoperable. But later they have started with this NACT, they responded and they're doing okay compared to those who were called inoperable was a final thing. Okay, but that 5-year survival, 3-year survival is only very bad. Okay, 17 to 20% hardly. Okay, and what was so in jaundice, if they present with type 1 and type 2 block, so you read there are 4 types of block. Okay, if they present with type 1 and type 2 block, this is based on where it is involving. I mean the confluence or where exactly is involving. So type 1 and type 2 block, they have better survival compared to type 3 and type 4 blocks. Okay, then that's about jaundice we discussed. Yeah, NACT GEMS is can you tell me doses?
Doses don't know. I have to read.
Anyone? Gemcitabine dose?
Split in 75 or 100. अब इसमें क्या देता है I don't know.
It is same. Gemcitabine 1000 mg. Okay.
Okay.
So that is Gemcis. Okay. Can you tell me were there any studies of individual gemcitabine, or you have to give two drugs? Were there any studies?
Bill cap is the study for adjuvant capsatabine. For neoadjuvant
Okay.
setting, they are saying ki what we are using for palliative setting, ABC or Accord and Broadridge. These are all for
So,
adjuvant setting. So for these GEMSIS is for palliative setting. So for NACT, they are saying the drugs which are using can be used for NACT. It is not separate trial for any NACT.
so whatever for gallbladder has come, no, it's all extrapolated from cholangio only. Okay. So nothing in specific only for gallbladder cancer, so except for this borderline resectability and neoadjuvant chemotherapy. Most of the studies have been extrapolated from cholangioCA itself. So as you told, the bill cap was that which is told about adjuvant capacity. So what did it tell?
Post-operative, if patient stage is more than T2, then adjuvant setting, if we are giving capsatabine, there will be OS benefit.
Correct. Good. So any T2B and above, it is sorry. Any T1B and above, it is it mandates adjuvant treatment. Okay. So what about suppose what else? Yeah. Any use of radiation?
For if R0 resection is not done, positive margin is there. For R1, there is a role of CTRT according to SWOG 0809 trial.
Okay. So it has showed some benefit of few months. So double 8 months and 15 months, I think, if I'm not wrong. And so there were some adjuvant chemo-RT regimens also. Okay. So anything apart from GEMSIS you can use?
Nowadays, ma'am, Capox.
Gemox, correct. Gemox. Gemox also can be. Okay.
Nowadays, a
Generally,
role of ma'am PDL1, pembrolizumab, durvalumab came into the picture.
yeah. Targeted treatment can also be used.
Topaz
Okay.
trial.
And
Topaz trial.
Topaz. Okay. So what about the resection after post NACT? How much is it? What was the trial saying? How many people will become resectable and will achieve R0?
50% only.
Correct. 50%. Okay. Then so what? So if there is spillage, as you told, surgeon told you there was spillage, okay, and in your this one, then how does it affect your? There was some bile leak, okay, post operatively. So it was controlled by conservative means. So what all? So how would be your plan of management be there in that case?
So in that case, ma'am, I would like to give NACT only for that patient and observe for if still there is no disease after 3 cycles of chemo, then I would like to go for completion. If it's coming like a peritoneal disease diffuse, then we can avoid surgery in that patient.
Okay, NACT basically. So what's your idea about port site removal?
Usually there is no benefit of doing port site excision. But if isolated port mets after completion of all chemo treatment. If isolated
Can you
portal
can
disease, then we can do
So,
resection.
port site as such is a metastatic disease. Okay,
Yes.
you should remember and always explain the patient about the prognosis of the same. Okay. Any role of brachytherapy, Saumyta?
I'm not aware, ma'am.
Yeah, there are some studies from Japan. Okay, intraoperative radiotherapy and brachytherapy they have done, but there was no level 1 evidence as such. Okay.
Okay.
Then, so when will you time the completion cholecystectomy post first surgery? Ideal time.
Within 8 weeks.
4 to 6 weeks.
Within
Okay.
4 to 6 weeks. Okay.
So we discussed about the adjuvant treatment. Yeah, immunotherapy you told to pass trial. So same things which comes in cholangio, you should remember all the trials, ABC, BILCAP. Okay. What is ABC assessment for any hepatobiliary cancers?
CA pancreas, that is anatomical, biochemical, and C is for CA 19-9.
Conditional.
Performance status. Okay. The serum markers and the anatomical. Okay. So yeah, then adjuvant follow-up. Tell me follow-up.
Follow-up, ma'am, after radical cholecystectomy and after completion of treatment, we will ask patient for 3 monthly follow-up till 2 years with ultrasound and CA and CA 19-9. If any symptoms or any clinical, then we will go for cross-sectional imaging. And then after 2 years, 6 monthly follow-up till 5 years, and after that yearly. पर usually gallbladder yearly follow-up तक बचता नहीं है patient.
Okay. What is your idea about minimally invasive surgery and HIPEC? Then we'll close this session.
As of now, for of my knowledge, HIPEC, no role of HIPEC for hepatobiliary cancer at present. And minimally invasive surgeries, some reviews and meta-analysis are there who are saying minimally invasive is safe and less morbidity and can be done as per the expertise of the patient, physician or consultant.
Yeah, it can be done, but generally they'll not get that clearance of the lymph nodes. Okay, especially near the porta hepatis. Okay, so it is difficult to clear, and most of them the lymph nodal yield was not very good. Okay, so training is required before you call it that as a standard of care. So no, as of now, they prefer open surgery. Okay, and even the assessment of para-aortic lymph nodes and all, the feel is important compared to minimally invasive surgery. Okay, robotic is the same. Okay, and I think more or less we covered here. Anything if we have left, you can just.
We have covered everything. Risk factors का relative risk I have to mug up.
Yeah, that theoretical part you read. This is the main management part from this one we have covered. Okay, theoretical. Now, what are the causes of etiology of gallbladder cancer? Okay, what are the like relative risks? All this you read up.
So when they ask that about Murphy sign and all, they are asking.
Yeah, they ask. They do ask. Okay, because as I told you, most of your examiners are old timers. So they believe in theory rather than practically what is done. Okay. So generally, if they are good examiners, they'll ask you the practical aspects. But if they want to like drag you, they'll start with anatomy. They'll start with blood supply. Okay. So that's how they can
Actually,
the end of discussion.
gallbladder and hepatobiliary, there is very aberrant anatomy. Not everything, every time, it's not simple.
Yeah, we all know basic anatomy, but down the lane we'll know what are like abnormalities, okay, and all those things once we start doing surgeries and all. But as I told you, if they want to retain or pull our leg, show you,
So
get
for
you down.
cystic duct and cystic artery, we have to ligate. It's originating from right hepatic artery. It's very good. If it's not originating from right hepatic artery, then also we will ligate cystic artery only. Na? I
Yeah, we
don't.
will like it. No,
So,
we'll like it. Okay, first you have to confirm whether that right hepatic artery aberrant anomalies. Okay, then you have to see the vascularity. You will do that keep a bulldog clamp, see. Then all this aberrant anomalies of right hepatic and all will come more commonly in Whipples. Okay, for gallbladder generally you don't see anomalies. Very few. Okay, so
or liver
uh,
resections also, if they are, that we have to see all portal venal connections.
generally, see, when it mandates major liver resections, not in gallbladder. So, how many gallbladders will do the major resections? Even if we do, how much they'll survive? Yeah, it is poor prognosis, no? So, that's all. And complications of surgery, I forgot to ask. Last point, and then we'll finish.
Complication of surgery, bile leak.
How do you
Or
manage bile leak?
it's we usually put drain in our setting. So if a drain is less than 100 or it's decreasing trend, we are monitoring. Patient is vitally stable, so we
So,
wait
what is
and
high
watch.
output bile leak? What is low output bile leak?
High output and low output bile, ma'am, that now amount I am not sure. It's more than
So,
300
anything
or
other
less
than
than 300.
pancreas? Yeah, anything other than pancreas. Pancreas has 200 cutoff. Okay.
Okay.
Whereas other than that, all are 500.
Okay.
Okay. So generally, if it is small leak, what is the most common site of leak? It is cystic duct. So if it is small leaks, they can be managed conservatively. Okay. So it will come out through the drain, or you can take them for stenting. You can keep them for if like some embolization techniques and all. Okay, all this can be done. Conservative measures. It will generally settle down. Okay, over time it forms a controlled fistula and it will settle down. But if it is a bile leak that is increasing, okay, it has come in 750,000 ml, then you need to intervene. Okay, the worst case scenario, you will need to go and do a right hepatectomy. Okay, or hepatic hepatico-jejunostomy. Okay, these two things are that are there. Okay, other than this, you will generally look for the nutritional status. Okay, bleeding के लिए embolization करेंगे, infection other. So these are the comments. Shall we call it a day?
Yes, ma'am.
Yes,
Thank you,
ma'am.
ma'am.
Thank you, ma'am.
Yeah. Okay, bye.
Next will be on Monday, ma'am. Monday, so you are busy day, na?
Monday.